All right, perfect. Just give me a second. I'm very glad today. So, good morning, everyone. Welcome back to our international ground round. Today's guest is one of my friends. We spent time together when I was in Varese. He was doing his fellowship on rhinology and skull-base surgery with the Maestro Castelnuovo. I'm very glad today to have Shawkat Abdulrahman from Ireland, ENT consultant and rhinology consultant, Dublin, Ireland. Good morning, Shawkat.
Good morning, my friend. Nice to see you here again.
It's a pleasure for me to stay up to date with you today because today Shawkat is going to talk about the GPA and the role of otorhinolaryngologist. So please, Shawkat, can you press the share screen and choose your presentation?
Okay,
Great.
good. So you can see it, right?
Of course. Please go ahead.
Okay, so thanks again for inviting me for this presentation. And we have to get benefit from being quarantined at home with not such an clinical activities as we used to do before the COVID era. So my name is Shawkat. I'm a consultant rhinologist in Dublin, Ireland. I'm going to present today about the juvenile the granulomatosis polyangiitis, which is a type of vasculitis, although it is more or less like considered a medical, but there is some contribution with the ENT. Vasculitis, as you know, is generally an inflammation or heterogeneous group of systemic inflammatory disorder that lead to blood vessels structural injury that will lead to ischemia, ischemic manifestation. So what's the granulomatosis with polyangiitis? This is the first question that we usually being asked whenever we say GPA, which is a vasculitis that is ANCA-associated small vessels vasculitis. This group of small or medium to small size vessels vasculitis has many, let's say, disease. One of them is microscopic polyangiitis. The other one, which is GPA, which is used to known by Wigner granuloma or Wigner granuloma. And the third disease, which is Church-Strata syndrome. So here I'm going to talk about the GPA. As you remember, when we were discussing about the subject to present, you were asking why we change it. As you know, it historically is described by Dr. Frederick Wigner, who is a pathologist, German pathologist, died in 1990. Although he described it in the 1936, but recently the International Panel of Experts in Vasculitis, they recommend to change the syndrome from Wigner granuloma to granulomatosis with polyangiitis for a couple of reasons. One of them is a political reason. So let's start with the clinical things. Epidemiology, how frequent we can see it in your practice, Puya? How frequent do you see such cases? It's not that common, it's very rare. And even it is more or less 4 per million as reported in the United States. As we are part of Europe, the highest rate we can find it in Norway, which is around 15 per million. And if we consider which group is common, you can find it in pediatric, and also you can find it mostly in adult. In the adult at any age, but the onset start around 40s. Male to female ratio more or less is similar, but more with dominant with the female. Caucasian are overrepresented, as we say that with Norway, they have more presentation of such disease. Said earlier that even pediatric, we can find it in the range between 4 to 17 years old. Mean age is 14.7. Female to male ratio is also more predominant in female. Pathogenesis, this is many, let's say, pathogenesis that suggests that we have the Wigner granuloma or the GPA. One of them, which is genetics. I have current a case and we are investigating that the patient's sister has also maybe a start of Wigner granuloma. Therefore, we are trying to do some genetic study on it, on her. Also, the other pathogenesis for the GPA is ANCA, which is human autoimmune association. And the third pathogenesis and environmental influence on the, let's say, immune system, such as infection. Therefore, some studies show that if there is like a contribution of Staph aureus and induction of Wegener granuloma or the GPA, special in rhinosinusitis. So if you want to establish the diagnosis, how you are going to do that? Generally, as a basic thing, so you have to focus on the 4 squares that I have it shown in the slide here, which is the clinical features, laboratory, imaging, and biopsy at the end. So we start with the clinical feature, how it's present for us, the vasculitis, which is the GPA. Usually is mostly as around more than 70% of the presentation with upper respiratory tract symptom, lower respiratory tract less, kidney also you have up to the 60%, and other manifestation. We say that the upper respiratory tract infection, which is let's say is the group that the ENT deal with, which is sinonasal, otological, laryngeal symptom. The most common things is the sinonasal. Usually they'll present with mucous inflammation or chronic sinus infection, or even nasal crustation, which is, I find in my practice, is more common because the first things, mucous inflammation, chronic sinusitis is a common symptom, so you cannot exclude it. But once you have a nasal crustation, bloody rhinorrhea, it means that you have more advanced presentation. Septal perforation, as you know, is one of the causes, the presentation that caused by autoimmune disease. The nose, what are the, let's say, present, as we said earlier, 70 to up to 100% of the cases. The patient that I have present with chronic sinus infection, sinusitis, and progressed more. Ear, as I know, Puya is more an otological guy. Is usually you will have an otitis media with effusion as around 40 to 70%. As you know, the upper respiratory tract is all connected, especially through the Eustachian tube and ascending infection. Also, there are some reported cases that sensory neural hearing loss that occur in 35% of the cases. Facial paralysis also present. And the interesting part also in subglottic stenosis, one of the things that we have to put in our differential if we have subglottic mass, and we have to rule out granulomatosis disease. So laboratory work, once we have these symptoms, then we have to send the patient for a blood test. It depends center to center. Usually we recommend that we should have like a checklist for vasculitis that will range from general things, which is the full blood count, urine and electrolytes, and ESR and C-reactive protein and urine test. Because most of these patients, they have, plus the upper respiratory tract symptom, they have a renal hematuria. Therefore, you have to investigate about the renal function also. The specific things for, let's say, immunological test, we have the indirect immunofluorescence test, which we will have the C-ANCA and the P-ANCA. As you know, the C, which is stained, the cytoplasmic is more common with Wegener granuloma or GPA. The P-ANCA, which is staining the perinuclear part of the test, which is more associated with other vasculitic syndrome that was, as we said earlier in the first 2 slides, Church-Stratus syndrome. Once we get these tests, let's say positive and suggestion, we move for the direct test or more specific one, which is the anti-PR3, which should be confirmed the indirect test. So the sensitivity of C-ANCA is around 91% and 99% specificity. Once we did the lab test, we find the clinical feature in lab test, we move for imaging. When you will do imaging, as part, we say that we will have these patients mostly present with upper respiratory tract. So usually we send for the scan just to check as part of the protocol of sinus infection, to check the severity, Some, if you have orbital manifestation, also you have to do an orbital CT scan or imaging, including even the MRI, to check if there is an intraorbital mass and to investigate further. You have to do a chest X-ray. This part of the protocol to check if there is any widening or lymphadenopathy in the chest. Also, you have to do, let's say, a test for the lung parenchyma involvement. And later on, let's say most of the cases that they will investigate about vasculitis, our rheumatologist or the medical team, they will send patient to check the nose and to check biopsy, which is very common for the ENT. So we will take like a mucosa, nasal mucosa biopsy, although it's not that diagnostic in up to 50%. I have the patient that I'll present later on. I did a couple of biopsy over 1 year. And only after 1 year from multiple biopsy, I got a positive that indicate the patient has an active stage. And is usual if you take a nasal biopsy, it will not give you like as expected result. If you take more deeper biopsy from the sinuses, you will get more chance to have a proper result. Also, the lung biopsy, whenever there is, although it will not done by us, it will done by the interventional radiologist or renal biopsy. It depends on the symptom of the patient. So after we finish these 4 things, the clinical presentation, the laboratory, the imaging, and the biopsy, you will have finding. And there is like a criteria to diagnose the Wegener granuloma or the GPA. The first criteria that we have is 1990 by the American College of Rheumatology, where they have 4 items or parameter, which is the nasal or oral inflammation that include, as we said, discharge or ulcer or perforation, abnormal chest radiography finding as Haller like nodules or infiltration. If we have your kidney manifestation like microhematuria or biopsy result. If you see from these 4, you will not find the laboratory test about the C-ANCA and the P-ANCA. So initially, they state that if we have any 2 or more of these criteria, it will give you the diagnosis. But later on, in 1994, they upgraded this criteria where they added the ANCA finding. Even though they recently in 2012, they revised it and they make the diagnosis, any necrotizing inflammation of the upper and lower respiratory tract plus vasculitis, necrotizing vasculitis, which is proven by biopsy. So you have the diagnosis. You always say, you will have variety of presentation clinically. Sometimes you'll say that, okay, this is a localized vasculitis, or you will say that, oh, we have a severe vasculitis. So there is a criteria to define it. We will need such things. As I said earlier, I have 1 patient that presents with suspicion of vasculitis over 1 year. And later on, it presents with a positive finding for us. So it's either localized when you have only specific, either the upper or the lower respiratory tract without any systemic involvement. Or if you have an early systemic, any of these cases, but without organ-threatening or life-threatening disease. Generalized when you have the renal involvement, and it will be more with nephrology team. And further, we have the severe and the refractory. So what next after you establish the suspicion and all this information? As you know, it is very rare disease that you don't find it or you don't face it in your clinical practice a lot. We don't have too much mention in the literature. Fortunately, in Europe, we have the European Vasculitis Society, which is a cooperation between the multidisciplinary team all over Europe and even from the Northern America. In my center, where I'm, let's say, practicing in Dublin, I'm lucky to have the vasculitis multidisciplinary team where they discuss in twice weekly, twice per month, or maybe once monthly. It depends on the cases that we have and we agreed to discuss. So you will need, in such case, a team cooperation that will consist of from rheumatologist and the ENT, or it depends on the, let's say, the cases that you will have. Why it is very important for us? Because if you don't diagnose vasculitis, it has a lethal disease with mean survival of 5 months. Fortunately, if you are lucky to diagnose it and you start with the proper treatment, you will decrease the mortality more than 50%. In spite of that reduction, we still have around the 5-year survival rate range from 74 to 78%. However, the first year mortality is still high, which is around 11%. And what's the treatment that we have? The idea from the treatment is to induce remission and then maintain it. It's an autoimmune disease. We would like to control the case that will not change from localized to, as we say, the clinically division, from localized to severe to refractory. So there is a couple of regime that is recommended and will be updated time to time from center to center. But initially, they will start with intensive immunosuppressant regime, plasma exchange, anti-tumor necrotic factor agent, and the chemotherapy. The best combination that is very common for everywhere, they use combination of oral immunotherapy plus corticosteroid, which improve the remission rate up to 93%. The maintenance as ENT, usually we start with very high dose. Imagine that you will have a sensory neural hearing loss. Usually the protocol, we start with very high dose of steroid, then we taper it. But in this immune disease, we have also the same start with very high doses, which is maximum around 80 milligram per day. Then we'll start to taper it over 3 months. Then we'll keep a maintenance of 10 milligram per day for 6 to 18 months, till that we get a stable remission, maintain the remission state. This is generally. Regarding the ENT, the patient, in spite, such patient will follow a combined clinic, which is rheumatology and the ENT, or the nephrology and ENT. With the nose, what we have to do, as we are familiar with the European position paper with nasal polyposis, there is a typical, let's say, a routine care for the nose that will range from local care, nasal irrigation, nasal steroid, with plus minus course of antibiotic. As we said earlier in the pathogenesis, there is some studies showed that there is a role of Staph aureus in inducing or maintaining the vasculitis. So they recommend the antibiotic for that too. Do we have to do a sinus surgery or surgical intervention for such patient? It depends, but most of the cases I don't prefer. The patient that I had, I received a call from the emergency department that this patient complaining from headache and pan-sinus infection, and she was only 1 week before the after the biopsy, and when I get the biopsy result that confirmed vasculitis, I referred her to the MDT nephrology. And meanwhile, waiting for the MDT discussion, she visited the ED doctors, and they performed a CT scan to show pan-sinusitis, and they mentioned, oh, you have to take an action. I told them I will not touch this patient because she is still in active disease. So there will be no benefit from that, unless that there is a very, let's say, like sign of frontal sinusitis. The other things, if such patients, the nasolacrimal ducts is part of the nasal cavity that might involve and get the blockage. Do you do DCR for this patient? yes, you can do, and it will improve the epiphoria, but we will always try to avoid any surgical intervention in the nose in the active state of the disease. As we said, also there will be like destruction of the cartilage. Usually they will present with septal perforation. Even the cartilage, it might dissolve all, and they will develop like a saddle nose. So do we do reconstruction for such patient? You can do, but if you study, or if you navigate or survey about the published articles, you will not have a rich experience about the rhinoplasty to reconstruct the dorsum or the lower cartilage. But there is like one article which is around 45 case, and they use different material, autologous and even fresh frozen, or even the bone. So if you can see, there is different technique, there is different reaction. Some you will get rejection in 1 week, some you will get rejection in 2 years, but the principle is not to do any surgical intervention to reconstruction for the nose unless you have an active disease or under remission. The best graft that you will use is the L-strat graft. And whenever you reduce the number of the graft that you are using, you reduce the rejection rate. So the use of autologous tissue and the L-shaped strat for reconstruction had the lowest complication rate, and complication appeared to increase as the number of individual graft increase. Some will say that, okay, if I don't have a cartilage to harvest, patient refuse to take from the cartilage or refuse to take from the rib. So what I will do, what's other option that I can do? I find that you can use also the irradiated or the fresh frozen cartilage. This is an American company that they supply with the fresh frozen cartilage from a cadaver, is a irradiated one. The other things that you have, as we said earlier, one of the presentation is septal perforation for the patient. I know that you are familiar with the anterior septal flap that we use in Varese in our group, but there is different option. This is very nice article by the Dr. Al-Obed from Barcelona, where he categorized the according, if you have like a support for the septal perforation, or for the cartilage, for the septum, or if you don't have, and this depends on the size and what other option that you use. But I find that I feel more comfortable if I have the anterior, the septal flap that will base on the anterior ethmoidal artery. The success rate, I find it easier for me. And what about otitis media with effusion? As we said earlier, they may present with that. Do we do grommet? Yes, this is one of the options, but we always try to avoid that because the risk of chronic otorrhea, and hearing aid will be better option to deal with such patient. Even with the hearing aid, you will cover the conductive and the sensory neural deficit. Subglottic stenosis. See, such patient, they will present with subglottic stenosis, stridor. What do you do? Usually, if it is an emergency case, yes, you can do a tracheostomy. At least you'll secure the airway. But you always try to avoid that. How to treat the subglottic stenosis? They found that the best protocol is to use conservative laser combined with endoluminal balloon dilatation, and all these together, and intralesional injection of steroid. And they found that 50% of the patient with subglottic stenosis will require a tracheostomy at some stage, but always try to avoid that. And this is one of the cases, as I told you, that I'm going to present. Patient that she is in the early 40s, present to one of my colleagues where they with severe crustacean, rhinorrhea, some even bloody discharge from the nose. When we looked in the nose, there was severe crustacean, and we bring patient as day surgery under general anesthesia for nasal irrigation, cleaning, and biopsy. Over couple of years, she was under his care, then transferred to my care. I start to clean, take biopsy, clear. Then after 6 months, another crustacean, clean everything's also clear biopsy. Recently, I did the very deep biopsy, which come back as positive. What I noticed whenever we do a CT scan, there was a progressing from only a septal perforation. Now the patient has a severe destruction of the nose. If you see in the right side hand, the CT scan, as you see, she has an coronal CT scan, severe septal perforation, pansinus. There is no turbinate, as she had autologous turbinectomy. And imagine all this crustacean with this patient. So I had to clean all the sinuses and to take deep biopsy. Even I took biopsy from the tail of the remaining of the turbinate, which come back as positive. So for such patient, we refer her for the discussion with the MDT. So we have to treat her with, we did the blood test, which come back as cocaine-induced ANCA vasculitis, and they start her the rheumatology team with the cyclophosphamide and trexavam. And I'm going to review patient in usually in 6 months interval post chemotherapy. If she is stable, if she is, let's say, under control, I will discuss with her about reconstruction option, either for the septal perforation repair or for the saddle nose, and we'll move further from that point. Let's say to take home message is very important, the multidisciplinary team and early diagnosis. Always we have to have the suspicion. If you have a reluctant chronic rhinosinusitis and you already perform or you stick to the international guidelines and the proper surgical skills, in spite of that, you still have the ongoing chronic sinusitis, you have to think about a hidden cause, which is vasculitis. So always you have to have a high suspicious. During exams for our colleague who is sitting for a local exams in their country, including the UK, whenever you have a such case, if they will ask you, do you do reconstruction? You will answer definitely no, till the patient is clear or under remission. Whenever it's an active stage, try to avoid any surgical intervention. Although what I found in Ireland and Europe, there is an association between cocaine abuse and vasculitis, which is also whenever you have to take a history, you have to ask about that. And if they indicate that they are abusing, you have to have a high suspicion about vasculitic disease. Thank you very much.
Thank you, Shawkat, for the presentation. So it's like a huge review of the new evidence based on this, and we are really interesting to know exactly what are going to be the next future, because we, as a rhinologist, we always looking for treating patients not only with topical therapy but also surgery, and sometimes it's very difficult. So in order to do this, there's few questions from the audience we would like to address. We will start from the Zoom application, then we go to Facebook and YouTube. So Mateus, you said, is there a best saline for nasal irrigation in patient with GPA?
Sorry, say it again.
Is there a best saline for nasal irrigation in patients with GPA?
You know, it depends place to place. Usually we have the generic preparation that we have in the pharmacy. What we is locally present is Nelmed. I'm not disclosure, I'm not a consultant there, but usually you have to use what is available in your country, which is affordable. When I started my training, maybe more than 10 years ago, we didn't have this preparation. So we used to advise patients to use 1 liter of boiled water plus teaspoon of iodinized salt, and they shake it and they use it. This is depend on available option, but recently there is different uh, salines from different company, different country even.
We previously had a discussion with Joshua Levy from the United States. He was talking about the empty nose syndrome. And regarding to this, there's a question from France, and the colleagues is saying, what is the treatment if they develop suddenly an empty nose symptomatology? Because I think that is probably because some of them are, developing suddenly some such symptoms. So, what are your opinions in that?
My opinion is that we stick, in Varese, we were trying to do some study about implantation of fat to create uh, like a turbulent flow. But initially, whenever you don't have the inferior turbinate, even in the case that present the patient, uh, she complained about feeling of nasal blockage. When you examine, there is no inferior turbinate, which is similar to empty nose syndrome. So nasal irrigation with the patient, then you have to investigate about the cause, if it is iatrogenic or, like in my case, it is a vasculitis. So I have to treat the patient as vasculitis, stabilize the patient. Then we will discuss uh, what we can do. We might do the implantation to reduce the surface area inside the nose so the patient can feel the turbulence. How benefit it will be for the patient is depends. I don't have a clear figure about that. Usually, if I will do such for the patient, I have to discuss with the patient about the percentage of success.
Okay. There's question with acronyms. Please do remind that if you want to have your response, you have to write entirely the questions, because there's a question which I cannot address. So please do not use the acronyms. Second question is from Russia. Do they have an increased rate of malignancies?
Initially, we don't have, let's say, figures about that. Maybe in the future, if we have, because these cases very sporadic. We don't have a lot of cases that we can depend. We should have more uh, joint study between international centers, so we will have bigger or wider group to implant such a study. Even if I have patient, one of the patients that I had uh, present with cocaine abuse, then chronic rhinosinusitis, orbital cellulitis. When we did the radiology, there was an orbital mass, wasn't responding. There was no drainable abscess to rule out, let's say, orbital complication. Then I did biopsy, uh, let's say, through the medial wall of the lamina papyracea. It came back as lymphoma, and there is an association between cocaine, vasculitis, and lymphoma. I'm not that, let's say, uh, sure about that because we don't have too much reported cases. So we need to conjoin all the centers data to figure out such issue.
Okay, another question from Portugal. Is Staphylococcus aureus frequent in those patients?
There is some articles about that. There is the rules of Staph aureus uh, or environmental rule in breaching the or initiating the autoimmune response. Therefore, they recommend in sinus infection to use antibiotics with vasculitis. So there is a reported case.
Another question, can you then type whenever you can on Facebook that article so the people will get more information regarding this?
I already,
Uh,
I already, I already put in my presentation
Great.
everything that I mentioned. For example, the Staph aureus. If you see here,
Mhm.
the mechanism of the disease, pathogenesis, and treatment of ANCA-associated vasculitis.
Perfect. So another questions This is a private one. For subglottic stenosis and Wagner granulomatosis, how that you can perform tracheostomy or dilation, and how do you make the incision prior to dilation? Is it by incising at 3, 6, and 9 o'clock? And do you inject steroid following dilation?
Yeah, it will be like this. So it will, as you see in this scan, you have here, sorry, in this slide, you have the subglottic stenosis. As we said earlier, we have to try to avoid the tracheostomy, okay? And you should have a trained or subspecialized anesthesia team with you. So they will be like more or less, you will do the laser without the endotracheal tube. So you will start with the incision, which is around the lesion. Then you will do the dilatation with it. Injection, yes, you can do the injection after the lasers because you will remove the tissue, then you will inject. It doesn't make sense if you inject, then you'll do the laser because you will give more bulking, and you might, when you remove the laser, you might take out the part that with the injection. Then you'll do the laser with it. If you have to do the tracheostomy before surgery, you can do, but always try to avoid that. Even such patient, when you do this intervention, you have to keep eye post-operatively. They might get edema around the area and then get airway compromise. Therefore, you have to have a subspecialized post-operative team.
Another question from UK. Do they develop smell problems?
You know, as part of the crustacean, they will have, it will be blockage. And as you know, part of the mechanism of the smell, you will have a turbulent flow that will pass to the olfactory area. If you will have complete crustacean, they will have a mechanical anosmia.
Yeah, I guess. And this is a question from my point of view. This is just because I'm fascinated by those patients which are very complicated to treat.
Yeah.
Have you ever seen that psychological disorders are reaching to a decrease of immune responses that will lead to an increased manifestation of the autoimmune disease?
You know, it's such patients, although we don't have too much patient to conduct such study, but the available patient, most of them, they have cocaine abuse.
Yeah.
And usual with cocaine abuse, there is like personality problem. You need psychiatrists to follow with them. So definitely there will be such influence. Although we need, let's say, more, as we said, more data, more patient to figure out if there will be something. But I believe that, yes, there is some influence of that.
Great. Another question from Sweden, then we have time just for another one. Sweden is asking, do you suggest prolonged use of antibiotics and topical antibiotics, or you just oral antibiotics?
Usually I stick to the European position paper dealing with chronic rhinosinusitis without polyposis, because what the patient that will present for us, they will present with a chronic sinus infection without polyposis. So it's the same protocol. Usually I start with long-term antibiotics, local, you know, the proof evidence about that, the irrigation is the best. Then you will depend patient to patient to add the nasal steroid or oral steroid, local antibiotic or systemic antibiotic, long-term antibiotic. So it's depend.
And the last question is coming from, once again, Portugal. Do they have a concomitant asthmatic process or not? I don't get exactly this
Yeah.
question, but I can guess.
Yeah. It's not associated with vasculitis. It's associated with vasculitis, part of the autoimmune. But when they have asthma and nasal polyposis and vasculitis, you have to think about eosinophilic granulomatosis with cholangitis. So it's different subject.
Yeah,
So they
I
call it charge stratus syndrome.
Yeah, yeah. So let me do one thing. All right. So at the end of this talk, all of our audiences should understand what are the symptoms, what's the autoimmune disease, and then what are the treatment options. So you everyone have a clear idea of what is this disease or multiple diseases, because it's not just affecting one organ, it's multiple organ. So now it's time for a thinking or rethinking. So the possibility that you said regarding the surgery are aiming to do exactly a repair, or also helping the patient not developing other diseases or local disease. What's your opinion in that?
My opinion, first of all, as you said, is a difficult case to treat. Uh, Fortunately, in this time, is not different from 10 years ago or even 20 years ago. Now is a small world. We are connected by media. So the best things is to consult with other friends or other colleagues to discuss whenever you have an, let's say, unusual presentation. And as we said, you always try to avoid any surgical intervention in active state unless it is an emergency. Like if a patient has a stridor, you have to secure the airway, then you think about, because this is a simple ABC of the treatment, then you will think about the pathology and how to treat it. If it is sinus infection, always try to avoid doing surgery unless there is a severe complication that like a frontal sinus infection and there is uh, osteomyelitis of the bone. At that stage, no, you have to drain. So it's depend. Always try to consult. Regarding the reconstruction, is either for the septal, if you are, let's say, septal perforation, you have an option. And if you have collapse of the cartilage of the dorsum, you have also an option. When you will do that, this is the question. You always try to do the surgery when patient in remission and you feel the patient is, let's say, understand the severity of the disease for him. Because I have to be clear with the patient, the risk of the rejection of the graft or
Yeah,
failure of the procedure is unpredictable. So I have to be clear with the patient and I prepare him psychologically to accept, because he will present with you with nasal, with saddling, drop nose. So he
yeah,
already psychological, he's not happy about the result and the consequence for that.
yeah.
So I have to be clear with him always.
So it was really good. Thank you, Shawkat. I was pretty sure about your brilliant presentation. Before closing the remarks and saying a good weekend to everyone, I would like to stress once again the next appointment for next week. We are going to have on Monday Dr. Anderson Loy. He'll talk about the extended endoscopic and open sinus surgery for refractory chronic sinusitis. Then two interesting talk on Wednesday. We are going to have Paolo Tatiki, which is a friend of mine, who's going to talk about completely different talk and how companies can remain competitive in the new world. And it's very interesting. Paolo is a part of the Imperial College Business School. Is pretty good with all this new stuff. And then same day, 2 hours later on, Anil Josh is talking. Do you know Anil, right?
Yeah.
Yeah, so he's going to talk about the deviated and functional aspect of the disease. And then we are going to have the minimally invasive retrosigmoid approach for this weekend, and then the week after, more to come. So thank you so much, Shawkat, for the brilliant presentation. I really enjoyed that, and I really hope to see you very soon. I'm still missing those beautiful dinner we had together while in Varese.
Hopefully soon we'll meet in Varese.
I hope so. I hope so. I really love you. Thank everyone for participating, and I will see you on Monday. Ciao, ciao.
Ciao, ciao. Thank you very much. Bye.